Thank you, Dr. Newman, for that very kind introduction. And I'd like to say the title of my presentation, Roadmap for Continued Progress in the Melanoma Clinic. And while not officially covered in these slides, maybe I'll start with an aside. And actually one is continued outstanding colleagues, those of us multi-specialty working together. And hopefully that one message from this morning, perhaps not officially written, but will be a takeaway in terms of the different talks, but really outstanding individuals, such as from dermatology, Dr. Hsu, from surgery, Dr. Newman, medical oncology, Dr. Ma, you hear about shortly. So again, not officially covered in these slides, but I do want to call that out in the very beginning, that I think one important thing are many of us really committed to the cause, working together in a collaborative fashion. This is my disclosure slide, and these are all support given to the UW for clinical trials. So again, I've got no conflicts related to this presentation. I'll begin by giving a few melanoma facts. The first, and really important to emphasize, that early melanoma is curable. Melanoma, when caught, detected, recognized, diagnosed early, and managed early, is curable in most individuals. So it's that important fact that if you identify something on yourself, on a friend, on a colleague, on a stranger, that person goes in, gets it taken care of early. Early melanoma is curable. It's important, despite all the great advances we'll talk about, remember that one very basic important fact. The second is that melanoma that spreads to distant sites, so-called distant metastatic disease, is serious and can result in death. We'll talk about many advances, but in spite of those advances, it's also important to remember that fact, that again, melanoma that spreads remains a serious problem. Importantly, new treatments, and we'll emphasize those today, give hope. And that's an important four-letter word, hope, and are improving outcome for many patients with metastatic melanoma. So my lecture outline is shown here. I'll begin in the dark ages. I'll transition to the age of enlightenment. And I'll conclude with my vision for a better tomorrow. So the dark ages, metaphorically speaking, for patients with melanoma is that time before 2011. We had painfully few effective treatments. Median age in the 50s, median survival 6 to 10 months, and 5-year survival rate less than 5%. This can be summarized in a brief sentence: metastatic melanoma is a bad disease. Our treatment options before 2011 included clinical trials, and in my opinion, really offered the best opportunity for patients. High-dose IL-2 or interleukin-2, a very intensive treatment given in the ICU setting for really a very small subset of patients. And even then, the chance of responding, meaning getting smaller, 16%, 1/6, and durable responses, 6%. We had chemotherapy that had various forms of ineffectiveness. I list one, but they were equally ineffective. That's what we had. Clearly, a dark ages. But during these dark ages, there was many important things happening. There was much research going on in the research laboratory that ultimately found its way into the clinic. So these laboratory insights, these basic studies that were then translated into people, really resulted and offered the opportunity for what I'm using here by analogy, the age of enlightenment. So I'll give a few examples. And one of these laboratory insights was that some melanoma cells contain targets for therapy. Again, what one needs to identify are certain aspects about the cancer that's distinct and separate from the normal cell. You want to find something, a target, something on the cancer cell that can basically call it out, can distinguish it, can identify it as being different, and that can give you an opportunity for a therapy. Importantly, it was identified that some of these targets control what makes the cell grow. They're involved in what's called cell signaling pathways. So if one could target those pathways, one in fact could interfere with the cell growing and kill those cancer cells. That was a huge discovery and resulted in the approval now of many so-called FDA-approved therapies for patients with advanced melanoma. Initially, these were given as single, what are called BRAF kinase inhibitors. The target that's been exploited to a beneficial perspective, the greatest is the so-called BRAF mutation, that being present in about half of patients with cutaneous metastatic melanoma. Many Similar drugs were then developed, and it was then discovered that really these are best if given in a pair. So the currently approved pair, dabrafenib and trametinib, venurafenib and cobimetinib, and encorafenib and binimetinib, different pairs, BRAF kinase and MEK inhibitors. They basically go at targets in the cell that interfere with how the cell grows and can interfere with how the melanoma cell is growing. So that's on the positive side. That's great news. On the not as great news, the one obvious caveat is targeted therapies can only work if the melanoma cell has the target. As mentioned earlier, about half of the melanomas have the BRAF mutation. There's other targets, other therapies being developed, but again, still one prerequisite is that the cancer cell has the target for which this targeted therapy is identified. But even if the target's there, another overarching problem is that most melanomas develop BRAF inhibitor resistance. So again, these are important targeted therapies. They've helped many individuals, but the so-called median duration of working is about 12 to 14 months. They can work sometimes in days, sometimes in weeks, sometimes in months. Sometimes they don't work. The chance of working may be 70% or even better. But even when they work, and when they work dramatically, usually 10, 12, 14 months later, the cancer is growing again. So a huge item for further laboratory work is trying to identify mechanisms of resistance to these targeted therapies, and identifying new treatments to give in combination or subsequent to progression after BRAF inhibitor therapy. The second insight, and this one was huge, was that immune cells, or T cells, can recognize melanoma as foreign. Our T cells are those immune cells in our body that recognize foreignness from self. That's how we've really evolved as a species. We really have these T cells that can recognize infections and clear infections. Shown in this cartoon is the exquisite specificity of the T cell with its so-called receptor. Is that showing up there? Maybe not. But the T cell with its receptor recognizing a foreignness of peptide presented by the cancer cell or antigen presenting cell. They can second costimulatory signals. The important message is that we have in our bodies T cells that can recognize cancer as being foreign, as being non-self. This was a huge discovery. This discovery was way back in the dark ages. I remember these initial papers, these were back in the early 90s. So this was going on when clearly no treatments were working. But there was so much optimism, so much enthusiasm, because the immune system, when you think about it, is truly an ideal anti-melanoma weapon. There's a diverse attack. There's many types of immune cells we have, T cells I spoke about, NK cells, et cetera. And some of these have exquisite specificity in their targeting. They can see these minimal changes from self, and you can have these T cells then reacting against the cancer cell, the foreign cell. And immunity, if achieved, can last a lifetime after effective activation. This was clearly the promise of the effective immunotherapy. It raised the possibility of using the patient's own defense to fight against the cancer. The cancers are kind of smart. And we then basically, this was also going on in the dark ages, but we realized that we needed more strategies to get more melanoma reactive T cells. Part of it was a numbers game. As shown here, there were a few number of melanoma reactive T cells, huge number of T cells, and not enough to do the job. That was part of the problem. But the other problem, and even a bigger problem, was the presence of breaks. Our immune system has evolved where once the immune system is turned on, there's a natural defense mechanism that then turns it back off again. We're not always fighting the flu we had last year. We need to stay on our toes and basically fight the next infection that comes up. Similar to cancer, the T cell can initially be active, but then there's a break. There's a natural part of our body that then turns off that immune activation. It disables the T cells from being active. So the discovery, and this was huge, and this has revolutionized care of the melanoma clinic. It is now translated to many other clinics as well, other cancer histologies, is that if you disable those breaks, if you leave these T cells turned on, then the T cells can really fight against the melanoma. And shown in this cartoon is what you can then see happen. You can see these T cells, breaks unleashed, being able to go and potently attack against the cancer. This is coined or termed immune checkpoint blockade. again, this is really a revolutionary insight that happened again as the Dark Ages were starting to transition to the Age of Enlightenment. I'll give a few analogies to show how this is working. As many of you may recognize, this is a street in San Francisco. Pretend you're the car at the top of the hill, and the goal is to get right down the middle, past the stop sign, staying straight. These immune checkpoint blockade drugs take the brakes off. You point the car down straight, give it a push, and hopefully it gets right down past there. Cancer goes away. That's the goal. That's the strategy. That's the theory. Have any of you seen Lombard Street? That also exists. Take the car at the top of the hill, cut the brakes, give it a push, keep your fingers crossed. There can be cars parked on the side. There can be other items on the side. These are called immune-related side effects. What happens is the brakes are taken off all the T cells, both the ones you want to take the brakes off to get down straight, but also the ones that basically can result in side effects. And these side effects can be serious. These side effects can cause many so-called immune-related adverse events. These can be incredibly serious. It's important for the recognition: colitis, inflammation of the colon; hepatitis, inflammation of the liver; dermatitis, rash; hypophysitis, inflammation of the pituitary; thyroiditis, inflammation of the thyroid; adrenalitis, inflammation of the adrenal; pneumonitis, inflammation of the lung; and really many other itises, myocarditis, you name it. So again, many important and serious immune-related side effects can occur. It's really important for that recognition. But having said that, this is still a huge, huge breakthrough that has revolutionized our care. We've learned the importance of early recognition, early management, early detection. And what's also been discovered is that when you manage those, you can still have the good T cells that you want to have activated still do their job against the cancer. So right now, we have many FDA-approved immunotherapy drugs. IL-2 is still approved. It was approved for quite a while. We don't use it very much. Then we have the so-called immune checkpoint inhibitors. One's called anti-CTLA-4. At this point, it's a second-line treatment because we've developed better tools. We have the anti-PD-1 drugs, pembrolizumab and nivolumab. We've also learned that in the advanced metastatic setting, combinations are actually better. So nivolumab and ipilimumab, or nivolumab and relatlimab. They're better in terms of outcomes. They also have, as you might predict, more side effects as well. There's also a triplet putting in a targeted therapy with the immunotherapy. That probably has got a pretty small niche where it works. And for many of us, it's still not entirely clear if that's better than giving the treatments in sequence. And then, as Dr. Newman mentioned, TVEC for locally advanced disease. So I've been speaking about advanced disease that's distant metastatic, metastatic to distant sites. What's also been an important step forward is so-called adjuvant systemic therapies. So adjuvant means in support of the primary therapy. And the primary therapy in melanoma oftentimes is surgery. And we discovered that some of these treatments that have demonstrated effectiveness once the cancer spreads can also decrease the risk for recurrence. It's also increasingly recognized the importance of close and comprehensive collaborations between surgical oncology and medical oncology, and a newer approach, so-called neoadjuvant therapy. That's you give the systemic treatment first, then the surgery, then more adjuvant treatment. And actually, in some patients, that is a even better, further benefit than giving just the adjuvant therapy after surgery. And actually reported just earlier this year for the drug pembrolizumab, 3 cycles followed by surgery, followed by 15 cycles. So again, a full years of therapy is better than surgery followed by 18 cycles of pembrolizumab for patients with identified resectable disease. So again, this is a fast-moving field, an important one, but again, really gets at how I started my lecture with comments not initially planned, the critical nature, the essential nature of the close collaboration between the different specialists. So this slide was given to me by my actually friend and colleague, Dr. Michael Atkins, several years ago, and kind of summarizes treating melanoma, present and vision for the future. And this was in 2015, so these curves have changed a little bit, but still really makes the point that I'm trying to discuss here. What we had in the purple was what was in the past. We had chemotherapy and other types of ineffective treatment that essentially didn't do much for survival, very few long-term survivors. We then had the targeted therapies, the ones that I mentioned, and that improved outcomes, but fairly few long-term survivors. We then had the immune checkpoint blockade drugs, initially ipilimumab, and then nivolumab and pembrolizumab, then the combinations. And then actually with the combinations, we're seeing even 40 to 50% of patients with durable benefit. That's great, but you guys can do the math as well as I can. That's great for those patients. How about the 50 to 60% where it's not doing so? So I'd like to have the last part of my lecture be my vision for a better tomorrow and try to convince you that I really believe we have a roadmap for going forward. I will share a roadmap for a bike trip with several of my kids several years ago. We had a starting point and an end point and great companions for the trip. Our starting point are basically where we are now, with patients with a very serious cancer and need for better treatments. The roadmap there is shown in this picture. The roadmap in terms of the melanoma clinic is that really transformative insights in the lab will continue to guide progress. We have that roadmap. It's done it. I'm not just hypothesizing. There's clear evidence. I've given you some of that evidence. So I'll now briefly summarize 3 approaches actually in my research lab that we're doing to try to improve immunotherapy for patients with melanoma. One is trying to identify so-called predictive biomarkers of response to immune checkpoint blockade. We need to figure out for whom is this treatment going to work, for whom is it not going to work, who's going to get the side effects. I'll show you that strategy. We're trying to investigate new strategies to get more anti-melanoma T cells. We've got outstanding ways to take the brakes off. We can take that car on the top of the hill, get the brakes off very effectively. But we need to point the car down the middle better. And we're trying to get new strategies to make that melanoma better activate more more T cells that are anti-melanoma to then have more brakes taken off of those T cells. And then finally, we're also working with colleagues in the School of Veterinary Medicine to help pet dogs with melanoma. And by doing so, hopefully attain insights to help people with melanoma. So this cartoon summarizes our strategy to identify a potential biomarker. And actually one of our panelists this morning actually donated blood samples for many of these assays. We get blood samples from patients. We grow them under what are called selection conditions, where we can just pick up dividing cells. So we've got literally billions of T cells in our body. Using this strategy, we can only look at the so-called dividing T cells. We get rid of most of them. And then with those dividing T cells, we're trying to find the melanoma reactive T cells so we can specifically manipulate those T cells. And this work has been ongoing and is developing, and we're trying to figure out, are there ways we can best manipulate this response by figuring out those T cells specifically reactive to the melanoma. The second project is trying to develop a better melanoma vaccine to try to get more anti-melanoma T cells. And this study actually started several years ago. It's an intratumoral, meaning injecting the tumor immunocytokine. It's an IL-2 immunoconjugate given with radiotherapy to deplete some of the cells we don't want in there, and then with checkpoint blockade. Again, this is with several colleagues. This was really a study based on a really exciting laboratory studies from the laboratories of Dr. Paul Sondel and Dr. Zachary Morris, friends and colleagues on the Cancer Center. And in mouse models, this clearly showed that you could do far better with this treatment if you gave it into the tumor, had the tumor activate the rejection response, and then could give checkpoint blockade afterwards. The study is on a temporary pause due to change in licensure for the agent. But again, this is a study that we're pursuing at the Cancer Center. And then finally, working closely with our colleagues in the School of Veterinary Medicine. Again, these are not dogs we give melanoma to. We haven't given melanoma to a single dog. Dogs get melanoma like people do. The average survival of pet dogs with melanoma is less than 6 months if it's spread. So it's a bad disease in dogs. And we're investigating new treatments to improve outcomes for the pet dogs and really doing many biopsies. So I'm not a veterinary oncologist. I work closely with them and get the samples, the blood samples, the tumor samples. We're trying to understand what things are occurring with these treatments to inform what we want to do in people. So my take-home points. Laboratory insights have improved survival and changed the standard of care for metastatic melanoma patients. I think that is pretty clearly demonstrated here. Immune checkpoint blockade can achieve durable responses in metastatic melanoma. Awareness of possible immune-related adverse events is essential following treatment with immune checkpoint blockade. We need better biomarkers, both of response and of toxicity, and a lot of enthusiasm to look at combination therapies. I'd like to acknowledge the many colleagues, both in the lab and clinical collaborators, who identify here just individuals for these specific projects. There's many other collaborators for other projects. I'd really like to especially call out Dr. Cindy Zuliger, a very talented immunologist in my lab, and also Dr. David Vail, who heads up our veterinary oncology program. Funding is important, both through the VA system, the NIH, but actually something I never imagined decades ago when I started was really the importance and the benefit of philanthropy. And Ann's Hope has been incredibly beneficial, supportive of our work developing these biomarker studies. Steve Lutho Foundation, the Tim Eagle Memorial. It's something when your patient is cured and they give you something, but when your patient passes and the spouse, now for 20 years consecutively, has golf outings to raise support, tells you something. So this philanthropic support is really key to get the initial studies, to get the federal dollars to go forward. And while meaningful progress has been made, much more work still needs to be accomplished for patients with metastatic melanoma. We got a road, the road's exciting, but the road basically needs to be traveled. We're doing this together. Thank you.